Hello, and welcome back to what are we gonna name this show?
I don't know. Hansel and Gretel. Hansel and Gretel go live in the forest. I don't know.
Oh my goodness. Well, welcome back to Dr. Sosa's weekly live. How about on more normal name?
Oh, I'll think about it. I'm an author, I can come up with names.
Thank you for joining us once again. We are so happy for the response we are getting from our patients.
All those little things on the bottom is people who joined us?
Yes, you just figured it out!
I did.
Oh my
Oh,
goodness.
that's cool. If I could see, I could say hello to some of them.
Yes, that's what you're supposed to do on a live. But
All right. Bye, Glom. Oh, yeah.
Can't read.
Can't read. It's too far away. I see well enough to operate, but not to see.
Thank goodness he sees well enough to operate, guys. Not to worry. He can see. Well, welcome back. We are here once again. We have a few questions from last week, and we'll start with the questions, and then we'll get to the promised topic of the 3 numbers to live a long and healthy life, because that's what he told us he was going to talk about today.
My little favorite talks.
Okay, but these are directly from the patients. I'm 7 weeks post-op and haven't lost much weight in the last 3 weeks. Is that normal?
Yes, so we call it plateau. And what happens, and the people who plateau the longest are the people who lose weight really fast. So I have people that come in and in a month they've lost 40 pounds. And then they call me freaking out for 2 weeks they didn't lose any weight. It's normal to plateau, especially after a big burst of weight loss. Your body's metabolically readjusting. It cuts down your body thinks it's starving. Your hormonal system, your hormonal milieu, when you have bariatric surgery, thinks, I'm starving. Let me preserve the storage that I have to survive winter, to survive famine. So that's the way our metabolism responds. So it's normal to plateau. Don't worry. Plateaus, especially in the beginning, they can last a week or two, but eventually you'll see another big drop off and you'll keep losing weight. Now, permanent plateaus, you're a year and a half, you're 2 years post-op, when you have the same weight 3 months in a row, living your life normally, eating more or less what you eat all the time, 3 months in a row, same weight, that's your permanent plateau. That's where you're going to stay. To shift that plateau requires something. A lot more exercise or going on a calorie restriction from what you're doing.
So the next question kind of leads into what you just said, and we'll talk a little bit in Spanglish, so I hope you guys don't mind because we have a lot of Spanish-speaking patients. ¿Por qué estoy stuck hace 3 meses? And I think one of the things that we won't be able to answer this question exact is because we don't know how far along this patient is. Like he was speaking, there are different plateaus and different phases. But the important thing is if you're stuck and you still want to keep losing weight, you have to make changes to what you're currently doing.
Right. So, si estás en el mismo peso 3 meses seguido, eso es el plateau permanente. Eso es que ahí vas a estar si no haces un cambio significante. Cambio significante quiere decir consumir menos calorías o quemar muchas más calorías con ejercicio, especialmente lo que llamamos cardiovascular. Me acaban de poner que hace un año que te operaste, ese va a ser tu peso. So, si perdiste 30, 40, 50, 100, esa es la pérdida que te va a dar la cirugía. Cuando tienes el mismo peso 3 meses, esa es la pérdida que ya te dio la cirugía. ¿Puedes perder más? Sin duda. Pero entonces, ¿qué requiere? 1 o 2 cosas, o mejor la combinación de 2 cosas. Menos calorías consumidas, más calorías quemadas. Ejercicio. Si haces las 2, puedes romper ese plateau y volver a perder 10, 15, 20, lo que le falte. Para ese plateau permanente tenemos el programa de semaglutide, tenemos las dietas, la nutricionista, porque sabemos que la operación va a llegar a un punto que no va a dar más. De ahí en adelante tenemos que tomar los otros pasos si queremos perder más.
Una cosa que siempre le decíamos a los pacientes cuando teníamos los grupos grandes es que la cirugía te da 1% de lo que tienes que perder, no te da 100% de lo que tienes que perder. So, el otro pedacito ese es trabajo para el paciente. It's hard work. You gotta put it in.
The last 20% is on you, and I say that on the videos, on the introduction video. The last 20% is on you. That means exercise. That means really watching the calories that you consume. And that's why our program, our comprehensive program, is there for when you get permanently stuck. That's the time, okay, I got to go back to a nutritionist. I got to make a diet plan. I got to make an exercise plan. I got to see if there's glycemia or semaglutide or other things that can help me get off this permanent plateau. Permanent plateau, same weight 3 months in a row. Temporary plateau, you get stuck a week or two during the first year. Those are temporary plateaus. I'm going to add something because it brings up an interesting topic. And people say it to me all the time. Oh, hey, talk about what the surgery you did to Gloria. I cannot. It's called HIPAA. I can talk to a patient one-on-one. I cannot here on a live thing discuss a particular patient. The patient can discuss themselves. I cannot discuss. It's HIPAA compliance. I cannot go into the details of a particular patient or a particular thing. The same thing. I cannot have you guys give me your medical history and then do a medical opinion evaluation when we're in a public forum. It's against HIPAA compliance. We can discuss general terms, general concepts, general advice, but patient-specific things, I'm limited to what I can do in a public forum. Happens to me all the time. You operate on so-and-so. And I just nod because if you say to me I did, I can't. But I cannot say to you, I operate on so-and-so and I did this surgery. It's HIPAA compliance.
Yes. So, I've lost 50 pounds and had surgery in January. Am I doing good? So that's 3 months.
Okay. Rate of weight loss. Very variable. Are you a man or a woman? Are you young or old? Did you have a sleeve or a gastric? What weight did you start at? All those variables depend how fast people go. People say to me all the time, what can I expect to lose the first month or two? It's very different. If you start at 500 pounds and you're a man and you had a gastric, you're going to lose a lot faster than if you had a sleeve and you started a BMI of 35 and you're an older lady. You're going to lose a lot slower. But 50 pounds in 3 or 4 months, yeah, awesome. Amazing. Awesome.
Just think about it. And I love when he does this math for people, right? So 50 pounds in 3 months. By the way, you're not going to keep losing that fast.
Right.
But if you were, that would mean 100 pounds in 6 months, which would mean 200 pounds in a year. More likely than not, that is not what you're going to lose. So you lose a lot of weight in the first month. Now, depending on all the variables he gave you is how much weight you lose in that first month. But every single patient loses more weight the first month than the second month, than the third month, than the fourth month.
Right.
Because you are very, very restricted in that first month and your body is still healing and recovering and adapting.
Remember the phrase, it's the calorie stupid. So the first month, the first week or two, you're eating about 300 calories a day. Jello, soups, barely any calories. Then you advance, to full liquids, puree. Now you're going up to 600-700 calories a day. Then you first start eating real food. You're still kind of very tight pouch, swollen, etc. You're eating about 1,000 calories. 3, 4, 5 months later, you're going to be eating more like 1,500 calories. So obviously the weight loss will decrease as your diet gets better, improves, and you get more calories. Now, by the end of 6 months, your diet consists of a bunch of carbs, a bunch of potato chips, a bunch of, greasy food. Your weight loss is going to be way less than if your diet consists of 70-80% protein, 10% carbs, the rest in fats. You're going to lose faster. So the ultimate weight loss has to do also with what you put in your mouth. It's the calories.
Yes, definitely food choices. And going back a little bit again to the weight loss, it's a staircase. You see a staircase, there's a step, then you go down, then there's another step before you go down again. That is how your weight loss works. Your weight loss is not a straight line going down. It is a staircase. So if you drew a staircase on a piece of paper, that's the way everybody's weight loss works. So you have to get used to that.
Temporary plateaus, permanent plateau.
Right.
Permanent plateau, same weight 3 months in a row. Typically a year and a half after your surgery.
But definitely 50 pounds in 3 months is very good. But you're going to start losing less. So don't freak out when you start losing less. That's very important. Stay motivated. Okay. Okay. Oh, this is a comment from last week's live. She said, I'm drinking water, but not enough. And the tip you gave, I hope this helps. Thank you so much, Dr. Sosa. So yes, definitely. And if you weren't here last week or didn't see it, flavor your water. That was the tip of last week.
That was the tip. Flavor your water.
Yes. Okay. Who is a good candidate for weight loss surgery? I mean, they ask, am I a candidate? But we don't have the exact height and weight, so we'll say, who is a candidate for weight loss surgery?
Pretty much everything we do is by body mass index. It's very easy to get your BMI. There are a bunch of apps. You can Google it. Any app you use for information will have a BMI calculator. You put your height, your weight, it tells you your BMI. If your BMI is 30 or above, you should start considering weight loss surgery. If your BMI is 30, 35, in that ballpark, and you're already diabetes, high blood pressure, cholesterol, you should consider weight loss surgery. If your BMI is over 35, you should strongly consider weight loss surgery. If your BMI is over 40, you should have weight loss surgery. This is opinion. This is published studies. This is longitudinal studies where we compare people who have weight loss surgery, people who did not. The people who have weight loss surgery live longer, live healthier, more active lives. So the cutoff is about a BMI of 30. At 30, you can still get the weight off with medical management, but that's the time to sort of begin to think, if I can't get this under control, I'm going to consider weight loss surgery. Again, I was at a BMI of 32. I was considering it, and then I managed medically through all the processes to get it under control, so I didn't have weight loss surgery. But once your BMI is over 30 and you're stuck there for a while, you should begin to consider it. Over 35, definitely get the information, strongly consider it. Over 40, get it.
Okay, ¿cómo puedo saber el precio de la cirugía? So, el precio es variable porque tenemos varios programas, pero definitivamente si quieres más información, si dejas tu información aquí a través de Sosa Way, puedes dejar un DM y una de las coordinadoras te puede llamar.
Siempre nos dicen, ¿por qué no me dicen el precio? Díganme el precio. Es prácticamente imposible darle a una persona el precio. ¿Por qué? Depende cuál hospital escoge, cuál cirugía escoge, cuántos riesgos tiene usted. Por ejemplo, una persona que pesa 500 libras, la operación es más costosa, usa instrumento más avanzado que una persona que pesa 250 libras. Todos esos variables entran en el precio. Una persona que tiene problemas médicos grandes tiene que ir al hospital más caro, tiene que ir al centro de excelencia donde tenemos los equipos intensivistas, etc. Ese precio es más caro que el hospital para personas bajo riesgo, es mucho menos costosa. La manga es mucho más fácil para mí, para el cirujano, para anestesia, para el team. Se usa menos equipo. La manga es menos costosa que el desvío gástrico. Hay tantos variables que tenemos que ver la persona, qué hospital escogió. De vez en cuando hay especiales. Sinceramente, cuando nosotros estamos repleto el schedule, que es frecuente, no damos mucho descuento. Cuando el schedule está un poco más bajo, damos descuento. Cuando una persona se opera con nosotros y trae a un familiar, damos descuento por ser parte de la familia. Hay muchas variables, o decirle a una persona aquí, el costo de la cirugía es tal, es prácticamente imposible. Podemos darle guías, pero...
Y muy importante que damos... puede hacer una consulta gratuita por teléfono con la coordinadora y puede ser una consulta gratuita por teléfono con el doctor Sosa. Que así entonces se le puede dar un precio exacto.
Exacto.
Como estaba explicando el doctor, tiene que ver con muchos factores. Además que para dar un ejemplo de esos factores es la edad, las medicinas que toma, las cirugías que ha tenido, las enfermedades que tiene, el historial que tiene el paciente. Por eso que muchas personas dicen, ¿por qué la consulta? Porque ahí le vamos a poder dar un precio exacto para el paciente. No nos gusta decir un precio y después tener que cambiarlo después. Tratamos de ser lo más transparente y honesto posible. Por eso que damos la consulta gratuita para dar ese precio.
In English, it's impossible to give you an exact price till we know your BMI, your risk factors, any previous surgery, which hospital you're going to choose, which surgery you're going to use. That's why we have the free consultation. After the free consultation with me and the coordinator, yes, then we can quote you a price. But it's very variable depending on all those things. So we can't tell somebody this is the global price. We also run specials. Mind you, most of the specials are low risk patient, low cost hospital. So people go, but I saw a special and you're asking me for more. Yes, because you weigh 500 pounds, you had a heart attack, and we have to have all these other folks taking care of you at the center of excellence, which is more expensive. So there's lots of variables, which is why a consult will get you a good idea of what price you can get it at that time of the year, because that also changes.
And you can have the consultation over the phone, so
Yes.
it's very easy. Okay. Okay. Gastric 17 years ago, gained weight back. What can I do?
So what are the statistical chances of gaining a significant amount of weight or even all the way back? About 10% of patients. So think about it. If I'm operating on close to 20,000 patients, 10% of that, it's a lot of patients, which is why we have the nutritionist, the glycemia, the semaglutide, all these other things. These are all the other things you can do. Surgery-wise, converting a gastric to another operation for weight loss is possible, but it's very, very high risk, and I avoid it because we have all those other plans. Word of advice: if you start to gain weight, come see us then when you gain 10 or 20 pounds. Don't wait 5 years and come see us when you weigh 100 pounds. Yes, we're going to try to help you. It's not going to be much tougher.
Yes. So, short answer is, if you need help, call the office, make an appointment. You can either make an appointment upstairs, and you will most likely either see Dr. Sosa or you will see his nurse practitioner, who also sees the patients that are struggling with weight loss. And since I brought that up, I just want to touch on that really quick. Dr. Sosa sees all the patients after surgery. At their 1 week appointment, he will see you. After that, if you're doing well, there's a chance you'll see him. There's a chance you'll see the nurse practitioner. If you're not doing well, if you're not feeling well, you will see Dr. Sosa. So why do we have a nurse practitioner?
Well, I mean, think about it, guys. I operate almost every day, pretty much every day. I see dozens and dozens of patients who've had surgery. I see dozens of patients who want to have surgery. There's just not enough meat to go around for everyone. So we have nurse practitioner, what we call extenders. They help us take care of more folks. So the well follow-up, you're doing well. You're just here to check your height and weight, to get advice on right now what you should be doing, what you should not be doing, etc. That's the nurse practitioner. You have pain, you feel poorly, there's an issue, there's a problem, I will see you. Sometimes the nurse practitioner goes in, sees that there's a problem, comes and gets me. But if you're doing great, if everything is good, if all you need is some advice, etc., the nurse practitioner I've trained very, very well to take care of the routine, doing well follow-ups, and that's what she's going to do. If you regain weight but you're doing great, she has all the information on the weight loss programs, the back on track programs, so you're going to see her. If you have a problem, you're going to see me.
And if you want to skip the visit upstairs because you're doing well and you just need to get back on track, you can just directly call the nutritionist office, and they also have the information for all the back on track programs. They can tell you what the different programs are and the cost to those programs as well. So there's also that option that you have.
So don't be embarrassed that you regain weight.
Yeah.
Don't be embarrassed that you can regain weight. Don't think I have a magic wand that I can fix it. We have advice, we have programs, we have things. So some patients don't come because they're embarrassed. I gain weight, then I do something about it. So don't be embarrassed because you gain weight. Don't have the expectation of walking in the office and saying to me, I gain weight, do magic. It's not going to work like that. What I'm going to do is I'm going to give you a bunch of advice on how to re-lose the weight, what tools we have to re-lose the weight. So 2 things. Don't be embarrassed. If you gain weight, we're here to help. Don't expect magic. Expect to have to work to lose the weight again. It can be done. I did it. So
I always tell patients, I'm like, if I had invented that magic little pill that you just take it and poof, the weight is gone, I wouldn't be here. We'd be on a nice private island in the Caribbean somewhere. But unfortunately, we do not have that little magic pill. But fortunately, we do have a lot of tools that are readily available and a lot of advice. And again, we did not have surgery, but it is our lifestyle. That is why we call this the Sosa way. It is because it is our way. This is what we do. We do not give advice other than drink water that he doesn't do. But other than that, we do not give advice that we don't personally take that advice, practice that advice, try that advice, make sure it works. Because it's a daily decision. It's a daily struggle. It's a daily task that you have to do. And it's just like everything else in life. If you want to be successful, you have to work hard at it.
I mean, we have not a magic pill, but close to new magic, the semaglutide. But trust me, if you do semaglutide and you don't watch what you're eating and you don't start exercising, it also is not going to be wonderful. But it is quite wonderful if you begin to exercise, restrict your calories. It helps you amazing. So it's not a magic pill yet, but it's really, really effective. So we have the tools.
Yeah.
Don't be embarrassed, come in, but don't expect magic.
Okay. Will the gastric bypass take away acid reflux?
Yes. So the gastric bypass cures gastroesophageal reflux disease, GERD, reflux, heartburn. The sleeve does not cure it and may make it worse. So if you're having severe reflux, the sleeve should be avoided because the reflux can get really nasty to the point that even twice a day medication, you may still have heartburn. So you gotta choose the right operation for the right patient.
Okay. ¿Qué piensa de la manga endoscópica? How do you say
Endoscópica.
There you go. Ah,
La manga endoscópica es una brillante idea que no funciona. Básicamente, sin cortar el estómago, están tratando de coserlo internamente. Van por la boca y ponen puntos internos. Esos puntos internos no son duraderos, no duran. Imagínese si usted se pone puntos en la piel, están ahí, fuerte, duro. ¿Qué pasa después de 2 o 3 meses? Esos puntos se caen solos. A veces la persona no viene a sacarse los puntos porque se le caen solos. Eso es lo que pasa con los puntos, se caen eventualmente. Los puntos interiores se caen. Cuando esos puntos se caen, ¿qué pasó? El estómago volvió al mismo tamaño que era antes. La operación no funciona. Eso es una pérdida de peso ligera brevemente. Y tristemente, la operación cuesta mucho dinero, $7,000 a $8,000. Se puede hacer una manga por un poquito más que es permanente porque cortamos y sacamos ese estómago. No lo dejamos ahí simplemente cosido internamente. El estómago lo hemos tratado de coser internamente, no funciona. Lo hemos cosido externamente, se llama una aplicatura, no funciona. Yo hacía la operación de coserlo externamente pensando que iba a ser una operación más simple, que iba a tener éxito. Hice como 100 de ellas, no funcionó. Me da tremenda pena con esos pacientes. Cuando esos pacientes vienen y necesitan otra operación, le doy tremendo descuento porque hicimos algo que pensábamos que iba a funcionar y no funcionó. La manga endoscópica sé que no va a funcionar. No bote su dinero.
In English, the question is
the endoscopic sleeve. The endoscopic sleeve, does it work? No, it doesn't work. It just simply doesn't work. You're sewing the stomach from inside with stitches that are placed through a scope. Those stitches don't last. After 3, 4, 6 months, they break open. Your stomach is back to its normal size. It fails. Now, if it was a very cheap thing, if it cost a couple of $100 and you could do it once or twice a year, I'd be like, cool. But it costs about $7,000, $8,000 for something that has brief weight loss and not very significant weight loss. For a little more, you can have a sleeve, which is when we resect, we remove the extra stomach, and that is permanent. So the endoscopic sleeve, it doesn't work. It doesn't have long-term reliability.
All right, just a few comments. Hello and many blessings to you both. Thank you.
Thank you.
I love this doctor. You see, people like you on here.
So we figured out last week, I'm Dr. Jekyll. Mr. Hyde is the one that sees you in the hospital.
And best decision I ever did. You are the best doctor. Again, guys, don't make his head get any bigger. Come on, work with me here, people. Why is everyone telling me after 5 years you gain it all back? Not true.
So statistically speaking, the chance of not gaining it back is much, much higher than gaining it back. Most patients don't gain it back. Do some patients gain it all back? Yes. And those are the folks that tell everybody the surgery doesn't work. Translation, the surgery didn't work for me, but I have to analyze what I'm doing that the surgery didn't work. So there is a significant risk, 10% with a gastric, 20-30% with a well-chosen sleeve, 50% with a badly chosen sleeve, or weight regain. Is there a way to prevent it? Yes. Calorie count, burn, exercise, etc. That's why we're here. But the vast majority that have bariatric surgery, it works, and it works long-term.
So just real quick on that, again, it depends on the surgery you had and if you chose the right surgery for what you needed. So if you were a poorly chosen sleeve then yes, 5 years out, there is a high chance
Right.
that you have gained weight.
Right.
Now, if you chose the correct operation for you, for what you needed, for your weight loss, for your BMI, for your age, then it's the percentages he just gave. So just wanted to throw that little thing in there.
Yeah, failure rate is very variable. It has to do with which surgery you had, what BMI you started at, did you really change your habits, your exercise habits, etc., etc.? Did you use all the other available tools? It's complex. But yes, there's a failure rate for both of them. The gastric bypass has a lower failure rate than the sleeve.
Okay. Okay. 7 meses.
Oh, we have to do my numbers.
Okay.
Sorry, we have 4 minutes left, so I have to do my numbers. So, 3 sets of numbers for a long, healthy life. The first number is 0. I'm going to give you 10 seconds. Can you figure out the number 0, why you will live longer if you do that number? The number 1 killer in the US, still to this day, soon to be bypassed, but still to this day, is smoking. Smoking causes cardiovascular disease, lung cancer, all sorts of lung issues, all sorts of blood pressure issues, etc. Smoking is the number 1 killer. You should smoke 0 cigarettes if you want to have a long, healthy life. That is the best thing you can do for your health. Is if you smoke, stop smoking. If you don't smoke, never smoke. Number 2, I always tell people, what's the most important number for your health? People give me their age, people give me their blood pressure, people give me their heart rate. Some people get really fancy and give me their C-reactive protein value, which is really fancy. Statistically speaking, that's not the most important number. What is the most important number? 30. What's 30? 30 is the body mass index where you begin to see a decline in health and longevity. If your BMI is under 30, and the closer it is to 25, the better, your chance of having a weight-related early death from heart disease, cancer is very low. If your BMI is over 30, that risk begins to increase. The higher you go, 35, 40, 50, 60, the higher. So the most important number for your health after 0 is 30. Keep your body mass index under 30. Struggle to do it, fight to do it, have surgery if necessary. Keep your body mass index under 30. That's the best chance for a long, healthy life.
Number 3.
Oh, number 3 is a set of numbers. The number's 7-11. What is 7-11? I'm not a big gambler, but I'm a little bit of a gambler. There's a game, it's a game of dice, it's called craps. And if you know anything about craps, the coming out roll, when you first begin a set of plays of the dice, is the first roll of the dice, 7-11 is winner. If you roll a 7 or 11, you win automatically. If you roll something else, the game continues. But 7-11 on the come out roll is a winner. What does that mean? Luck. Luck is important in life. Sometimes, you run, you're healthy, you watch your diet, your BMI is 26, and the bridge collapses. Or an airplane engine falls.
Oh my God.
I love bridges. Or an airplane engine falls on you. Or you have a flat tire on 995, heaven forbid. So yeah, 7-11, you gotta have a little luck to live long, healthy lives. But 0 and 30 are in your hands. Don't smoke, keep your BMI under 30.
And get lucky.
And be lucky. I got lucky. Sometimes you make your luck. It took me a long time to convince her. Sometimes you just make your luck.
In the words of your daughters, I was too cool for you.
Like, Dad, you don't have a chance. I say, no, I'm going to ask her out. They're like, you don't have a chance. These were my preteen daughters. Yeah, it worked. You got to stick to it.
All right. So, thank you guys for joining us once again. We will be back next Wednesday. I think I have him convinced to keep this up. So keep your questions coming in. Keep
telling me I look young, healthy, and handsome, and I'll keep doing it.
And we are so happy to have Dr. Jekyll with us here live with a smile on his face.
If you're in the hospital, Mr. Hyde will be by later.
All right, guys. Have a great day, and we'll talk to you guys next Wednesday.
A great day.